will have attended that. And it's amazing that she's organizing these, and this is the first of a series. So there will be a few more to come, and I'm sure they will just get better as they go along. So the topic I thought I would start with is the question that patients think but are afraid to ask, or sometimes don't ask for a variety of reasons. But I think that the first point I'd like to start with is, why glaucoma? Why do we even, so many of you are on the Zoom tonight to discuss glaucoma? Well, there are a few unique facts about glaucoma, and I think the most important one is that vision is considered our most precious of all senses. And so if you look at a questionnaire where they asked people, what do they think the most devastating event, you can see that blindness was ranked as one of the highest devastating life events that can occur. And glaucoma is the leading cause of preventable blindness. So it's not surprising to see so many of you with us tonight. So what are some reasons why some people don't ask questions? And what are their thoughts when they get given a diagnosis of glaucoma? Well, I think in my experience, fear is a number one reaction. So one is fearful of the answer, because you may not want to know the answer, or you may think you may not want to know the answer because in your mind you think it's worse than it may or may not be. The other one is just fearful of the diagnosis, and therefore it's hard to think of the question that you may want to ask after that. So what I thought I'd do is go through some of the questions that people have that, in my experience, when I've just offered the information spontaneously, they said, oh, I'm glad you told me that. I had that question in my mind, but I didn't know if I should ask it. So the first one is that I will have symptoms of pain or decreased vision if I have glaucoma. And that's one of the things that people wonder, and they'll think, oh, look, well, I can't have glaucoma. It can't be that severe because I don't have any symptoms at all. I actually feel like I can see fine. And that's one of the mysteries of glaucoma, is that it's a silent disease. So that it's, and the analogy I always use, it's like the shark in the ocean, and the canoer is just carrying on doing their own business, and there's the shark behind them, and it's not until the very end, when it gets very close, does the shark have symptoms, does the canoer have symptoms recognizing the shark's presence. And glaucoma is the same. It's a disease that doesn't cause symptoms in the early stages or even the moderate stages. You have to really dig for symptoms and be very nuanced and detailed and observational to notice those symptoms, although they will be there. But then in the advanced stage, life is limited and vision is limited. And then people have their driving at risk, they have their independence at risk, they have an increased risk of falls. So when people think, oh, I can't really have glaucoma because I don't have any symptoms, but I don't want to say that to the doctor. That's an important thing to say, because actually you won't have glaucomas until late in the piece. The second one is that there is a cure for glaucoma. And so patients want to know, is there a cure for glaucoma? And they're afraid to ask. So glaucoma is a chronic disease. So there is no cure at this stage, but that doesn't mean there will not be a cure. And that doesn't mean there are not good treatments at the present time. So the treatments for glaucoma are expanding rapidly. And these include eye drops, laser procedures. There are some new minimally invasive glaucoma stents that have become available. And then, of course, there's the traditional bigger surgery called a trabeculectomy. And these are all the tools that your ophthalmologist has in her or his toolbox to address glaucoma. But I think that at this stage, there are a lot of good treatments, and that's the most important aspect. The next thing is that people want to know, will I go blind? And this is the question that they're afraid of getting the answer to. And sometimes when I've just spontaneously told one of my patients, look, your glaucoma is mild, you're not going to go blind, we just want to keep you having as much vision as possible. I've had patients break out into tears because they have really been fearful and worried about going blind from glaucoma and didn't want to ask the question because they thought that if they asked the question, they would get the answer that, yes, I'm one of the people who's going blind. And they didn't necessarily want to know that. So I would say ask your doctor, because chances are you will not go blind from glaucoma. And you may have some impaired vision or you may not, but the role of your glaucoma specialist or your eye care professional is to prevent you getting to the stage where you notice symptoms from your glaucoma. So we want to keep you in that asymptomatic phase where you don't have any symptoms from your glaucoma, because once the symptoms start happening and you start to lose vision, then every little bit of deterioration is something that may be noticeable by you. So the key to preventing blindness from glaucoma is two things. First, it needs to be diagnosed early. And second, people who are diagnosed need to comply with their treatment. And studies have shown that those are the two reasons why people go blind from glaucoma. If diagnosed early, glaucoma blindness is rare. It can still occur in rare cases, but if it's diagnosed early and the patient has treatment, the glaucoma blindness is rare. So I think the balance in glaucoma for your doctor is trying to balance giving you treatments that may have some side effects, whether it's drops, laser, or surgery, with the progression of your glaucoma. And really the goal is to keep you seeing until the very end without giving you as minimal side effects as possible. So that's the discussion you have to have with your doctor, and whether that's surgery or laser or medication, it's a matter of balancing those things up. In my view, I like to be a bit more, I guess, aggressive with managing glaucoma and being on top of it. And the reason for that is that there's a study that to me was interpreted differently than the authors of the study. So the authors of the study showed that most people keep their vision until the last 2 years of their life. And the authors of this study interpreted this as an excellent outcome. But I interpreted this as not a good outcome, because for me, it's 2 years too soon. I think that people should have their vision kept until their whole life. And sometimes that may require a little bit more aggressive treatment early on so that you have more nerve cells later on in life. And this is a balance that's tricky to obtain, and you really do need to discuss it with your doctor and to make it clear that, say, look, I'd like to keep my vision as long as possible. Sometimes I know that may mean you having to make the hard calls and suggest to me a more aggressive or more proactive treatment, but I want to have that discussion. And then after the discussion, you may decide not to have that. But I think it's very important to be involved in that discussion with your doctor and to engage in answering that question and deciding what is best for you. So the next question people ask is that, can I regain vision that I've lost? Or can lost eyesight from glaucoma be restored? And often they think that when they're going into surgery, that their vision is going to be restored. Very similar to cataract surgery. You have cataract surgery, and many of you probably have had cataract surgery, and then afterwards your vision is better. And so many people think that when they have glaucoma surgery, or they start glaucoma drops, that their vision should get better. And often people say, oh, I stopped my drops because my vision wasn't getting better. Well, in actuality, the surgery or any treatment for glaucoma, the aim is to prevent vision from getting worse. It's to preserve what you have, not to reverse the damage that has occurred. So that's why it's important to start the treatment at an early stage, to save the vision you have. So one of my colleagues in Australia, Ivan Goldberg, always uses a beautiful analogy of a piece of cheese, which is your vision. And he says that glaucoma is the mouse that kind of nibbles away at that piece of cheese. And you need to kind of remove the mouse from the cheese before the cheese is all gone, because you can't get the cheese back that the mouse has eaten. So that's an analogy to think of why it's important to use your drops that your doctor has prescribed, or to consider other treatment, because what you've lost at this stage, we cannot come back. Now, I'm sure one of the speakers in the future may talk about new research, and certainly there's new research in this area all the time. So false. Lost eyesight from glaucoma cannot be restored. So the vision loss secondary to glaucoma is irreversible, but with treatment, we can maintain it. The next question is treatment for glaucoma lifelong? Do I have to have treatment forever? And we see this commonly in studies where they have shown that people stop their eye drops after a while, and that's because they think they've had enough treatment. So they consider it like a course of antibiotics. They've been on it for a few weeks or a few months, and now it's time to stop because they think that's enough. But actually, treatment is lifelong. True. And once you start on your treatment for glaucoma, or once you've been diagnosed, you will be able to be on some sort of care and monitoring in the chronic for long term. So I always describe glaucoma to my patients as a marriage. So once you select your doctor, you're both going to grow old together. You're going to go through good and bad times together, and you're in it for the long haul. And so the treatment is for lifelong. Sometimes you may not need follow-up as close as other times. So if you're at a very stable phase, your doctor may say, look, come back in 9 months or 1 year. And sometimes if you're having a period of aggressive glaucoma progression, then your doctor may say, come back in 6 weeks or 3 months or 4 months, and try to manage it a bit more intensely. And it's interesting because glaucoma doesn't go in a straight line. And that's one of the mysteries to me, is that you don't start here and all of a sudden continue to deteriorate. You go stably, and all of a sudden you may have a bit of a drop, and then things stabilize again. So it doesn't necessarily have one slope going down. So just because your glaucoma has been rapidly progressing at one stage doesn't mean that it can't be flattened and plateaued at another stage. Equally, just because you've had mild glaucoma and it's been going along very gently doesn't mean it can't all of a sudden turn around and become aggressive. So that's why it's important to continue your appointments with your doctor and grow old together, as I always say to my patients. So those are the kind of the most common questions that patients tend to say, oh, I wish I would have asked, but I didn't want to ask. Now, if you've got any more, while I go through the next little bit of the talk, please write those down, and then Pippa will alert me and we'll go through them together. But what I thought I'd do is just go through a little bit about what glaucoma actually is, because that's another question that people actually ask, but often think that they're afraid to ask because they think, oh, that must be too basic. I shouldn't ask that question. But it's actually quite a complicated condition to get your head around. It's not an easy condition to understand. So here's a diagram of the eye. And towards the front of the eye, there's this gland that produces fluid. And the fluid of this gland goes through the pupil, turns around, and drains into a drainage sponge. So this fluid is circulating around the inside of the eye all the time. And the eye has a pressure, and it has to have a pressure. If your eye had no pressure, the eye would shrink like a raisin. And so the pressure in the eye keeps it nice and formed, kind of like more like a nice juicy grape, and it gives it its shape. So you have to have fluid in the eye. However, if the fluid in the eye builds up and you don't get drainage of the fluid of the eye, then you can get a buildup of fluid in the eye and a buildup of pressure. So if the fluid in the eye builds up, there's a buildup of pressure in the eye if the fluid is not draining properly, and that causes damage to the optic nerve. Now, the optic nerve is the nerve of sight. It connects the eyeball to the brain, very similar to the cable, very similar to this cable, for example, that I plug from my phone to the laptop. So it downloads the messages exactly the same way. And if there's pressure on the head of the optic nerve, it goes from having this shallow little indentation to being hollowed out. And that hollowing is a result of loss or damage to the nerve fibers. So here again is a diagram of the eye from the side profile. You can see that in this corner right here, there's a gland that produces fluid. And then the fluid goes through the pupil and it drains in the corners of the eye. Now in glaucoma, there's resistance to the fluid leaving out of the eye adequately. So there tends to be a buildup of fluid inside the eye. And that fluid can then results in a buildup of pressure, and then that transmits to stress on the optic nerve. And here's the head of the optic nerve, and you can see this is a normal one over here on the left, and that's nice and shallow. And on the right, you can see it hollowed out, and that's from glaucoma. And that's the hollowing of the optic nerve from the built-up pressure. Now some of you will say to me, but I don't have a high pressure in my eye. I have normal pressure glaucoma. So why am I still getting glaucomatous damage if my pressure is not high? And that's because about 20 to 25 years ago, we realized that glaucoma is not defined by one pressure number. So it's not like you get glaucoma when you have a pressure of 21. Glaucoma is a condition of what we call pressure sensitivity. So every person's optic nerve has a certain pressure that it tolerates. And if the pressure inside the eye goes above that level, then you start to see this glaucomatous change. So the next question you may be thinking, well, why is some optic nerves vulnerable to high pressure, not vulnerable to high pressure, and others are vulnerable to low pressure or normal pressure? And some of the answer to that is genetics. Some of the answer to that is if you're short-sighted. Some of the answer to that is probably your general health. And also blood pressure may be a relevant factor as well in providing control. So those are the various variables that we recognize, but there's a vast surge of research being put in to identifying other variables that are not in that list that are relevant. But we do know, for example, that if you have a family history of glaucoma, that you're 10 times more likely to get glaucoma yourself. So the common feature of all types of glaucoma is cupping, or that's the excavation or the loss of nerve tissue at the back of the eye. And you can get glaucoma at a pressure of 40. You can get glaucoma at a pressure of 20, but you can also get glaucoma at a pressure of 10. And that's because glaucoma is a pressure sensitive disease. It's not necessarily a disease of high pressure. And here's an example of two optic nerves. You can see the one over here on the left, which is the right eye, has this large pale area in the center of it, and that's advanced glaucoma, while the one on the left has a smaller pale area in the center of it, and that's not as advanced as the other eye. So here again is an analogy to try to explain to you the relationship between the optic nerve, the eyeball, and the brain. So you have the brain, and the optic nerve is this long white cable that connects the eyeball to the brain, very similar to this wire that you see that's connecting the camera to the computer. And actually, the optic nerve looks very much like a telephone cable. When you look into it, you can see all of these little fibers, very similar to the fibers of the optic nerve here. So I'll just pause there for a second before I go further and see if there are any questions, and then I will keep going to if there are any questions. Pippa, did you want to let me know if there's any questions?
Yes, there is a couple, Helen.
Sure.
I've got, is there a level where ocular pressure can become too low, and is this a concern?
Brilliant question. And yes, it can be too low. And that's exactly what happens is when the pressure in the eye goes too low, it shrivels up. The eye loses its shape and the retina wrinkles. And when the retina wrinkles, then you don't have the photoreceptors in the retina able to pick up light or create the sharp images that you may need. And generally, again, just like every eye is sensitive to high pressure, eyes have their own low pressure that they're sensitive to. And that can range from 1 to 7. So some people at a pressure of 7 start to develop the wrinkles in the retina, which is called hypotony or low pressure. And some people at a pressure of 1 are still fine and do not have that. It really is very much pressure person dependent. But in general, when you're getting to 3 to 5, there's a higher risk of hypotony. And it's because of this hypotony why there's a reluctance to offer surgery sometimes to patients, because if you operate and the surgery is too successful, you've taken the pressure from too high to too low. And then you have to go back in and operate to try to get it back up again. So exactly. So and that is the challenge for the glaucoma surgeon and the challenge for the glaucoma patient. And that's not often a predictable outcome. And that's why there's often this little tug of war inside the heart and mind of a glaucoma surgeon. Should we be recommending surgery or should we not for this patient? We don't want to do any harm or we don't want to make them worse, but yet we need to get on top of their glaucoma. So that's the discussion in our mind or in my mind when I'm seeing a patient who I'm considering surgery. Am I going to do more harm? Or is there, if I do it, are they at high risk for hypotony, or should we go ahead and do it?
So Shirley also had a question. Some people with low or normal tension glaucoma get their pressures down really, really low, but still progress really fast. She read that pressure is only one factor that drives glaucoma progression in a low normal tension pressure.
Yes, that is. And that is one of the mysteries, the dark side of glaucoma we don't understand. But I will share with you some of my theories of why that is. So this is an area that's ongoing research. So one theory that I think is likely to be plausible, and one that our lab has actually been doing some research on, is that glaucoma, the process of glaucoma and the high pressure induces some inflammation. And there's a low level of inflammation in the optic nerve. So when you decrease the pressure in the eye, you're actually decreasing the risk of the insult from the pressure causing damage itself, but you're not treating the underlying inflammation. And so therefore you have this grumbling low level of inflammation that is continuing despite now that you've removed the insulting problem, which is the high pressure. So you've removed the high pressure, but you've still got this grumbling inflammation. And that's causing ongoing stress and damage to the optic nerve. So that opens up a whole area of research called neuroprotection. How do you protect the optic nerve beyond just lowering pressure? And there's a lot of different research going on in this area on different mechanisms. One is to stop inflammation. One is to help strengthen the optic nerve fibers that are there. So that's one theory. The second theory is that although the pressure has been dropped when your doctor is measuring it, that people are still having spikes of pressure. So, and we know that people's pressures go up and down all day. So, and when you come to see the doctor, you're only having one pressure measurement. So it's like taking a photograph. It's not a video of what's happening to the pressures in your eye. And so what your doctor will often do is they may do something called a water drinking test or a phasing or 24-hour pressure measurement. Now, we don't really do 24 hours because we don't have hospitals to admit patients, but I do often bring patients in for 5 or 6 measurements during the day. So at 8:30, 10:30, 12:30, 2:30, 4:30. And that kind of gives me an idea of the range and pressure. Sometimes I'll tell them to come in on different days. If I have someone who is like you, who has normal tension glaucoma and their glaucoma is still getting worse. And then sometimes we do the water drinking test, which challenges their drainage pathway. So you have to remember that glaucoma has a little plumbing. It's a plumbing problem. There's a microscopic circuit inside your eye that produces fluid and drains it. And so what we do with the water drinking test is we give you a liter of water to drink within 15 minutes. There's a toilet nearby, so don't worry. And then you can have your pressure measured every 15 minutes for the next hour. And what we know from studies is that people who have glaucoma, their pressures go up with the water drinking test more than someone who doesn't have glaucoma. So they have a brittle drainage system. So usually it goes up. A normal person may only go up 1 or 2, and someone with glaucoma tends to go up with 3. I've had people go up 15 to 17 millimeters of mercury following the water drinking test. So it's a challenge on their system. And so that is another reason why normal pressure can, or low pressure can still result in progression. We did a study a few years ago where we took a group of people who had, they all had a pressure between 10 and 12. Half of them had surgery, which got the pressure between 10 and 12, and half of them were on medication. So you would have said all of them are well controlled. And we did the water drinking test on these patients. And the half that had surgery, their pressures didn't go up more than 1 or 2. But the group that had controlled with medication, their pressure still went up from 3 to 6 millimeters of mercury. So it showed that even with drops, there's still a bit of brittleness in the system and you're getting these spikes. And so that's what's causing the damage. So it may be that although you have a low pressure on occasion when you visit your doctor, that spikes through the day for unknown reasons, and we don't really know the reasons of spikes, will result in higher pressure causing damage. So in those cases, even though I've done surgery on patients who have a pressure of 10 or 12 and saying, look, I may not obtain a much lower pressure in your eye. I may only get it to 8 or 9, but I'm going to flatten the curve. You're not going to have the spikes that you've had previously. And the goal is that flattening the spikes will prevent you from losing more vision. It was a long answer, but it was a complicated question.
It's a great question.
Yeah, great question. Okay, throw another one at me, Pippa.
Okay, once you've had a trabeculectomy, does it prevent any more deterioration to that eye?
So again, that's a beautiful follow-up from what we've just discussed. So the surgery in that study that we did that actually flattened the curve was a trabeculectomy. So and so that's what flattened the curve. So really trabeculectomy is the best chance of flattening the curve and preventing glaucoma damage in terms of surgeries go. But again, not everyone gets the same result from a trabeculectomy. So, about 10% of trabeculectomies can fail and they may not lower the pressure at all. And that's a different question if that comes up. And sometimes it works, but it still doesn't get the pressure low enough. So you still need to use drops in addition to that. And sometimes in very advanced cases or difficult cases that you can have a trabeculectomy and be on drops and still not have the pressure low enough.
I've got from Hillary's asked, I use 2 different drops at bedtime. Speaking of drops, what is the optimum time to allow between? Is there a minimum time you should allow?
Look, that's a good question. And again, that's a balance so that you can put it in and it's practical and that you don't fall asleep between drops, and also that you leave enough time for one to absorb to the other. So generally 5 minutes is plenty. 5 minutes is plenty of time between drops. So I always say, put one in before you brush your teeth, wash your face, and then put another one in afterwards.
I've got another one here. Was the membrane peel I needed after 30 years of glaucoma caused by my glaucoma or by the trabs I had, or was it unrelated?
No, I think that it's unrelated. You just kind of got struck with a bit of bad luck. A membrane peel, for the audience who's not aware, is that you have the retina, and on the retina is very much like a dartboard. Whoever's seen a dartboard. So, you know, in the dartboard, there's a very small center of it that's worth a lot of points. And the retina is the same. And that small center in the retina that's worth a lot of points is the macula. So even though there's a lot of retina, most of the work in seeing central part of your vision is done by the macula. And a membrane, for some reason, as we get older, you can get a membrane, which is just a little layer of skin, translucent invisible skin that grows on top of the macula. It's not macular degeneration, because macular degeneration is where you're getting holes in the retina. And, while this is an extra layer of skin on top of it. And when that layer of skin grows, it can pull and kind of contract and deform the macula, and then that can give you wavy lines or distorted vision. But there is surgery for that, and that's called a membrane peel. And then they go in, remove the jelly at the back of the eye, and peel off that membrane. And generally, again, if it's done at the right window, where it's not too distorted, but distorted enough to make surgery worthwhile, it can have an excellent outcome and restore your vision to what it was prior to the membrane growth.
Right. I've got a question from Vivian. What age is glaucoma likely to start?
So glaucoma increases as we get older. So if we took 10 people over the age of 70, one to two would have glaucoma. If we took 100 people at the age of 40, 2 to 5 may have glaucoma. And then if we took maybe 10,000 people younger than 41 would have glaucoma. So it becomes more common as we get older. But that's not to say you should wait until you're older to get an eye check done, because again, if you remember what we talked about at the beginning, our aim is to keep vision for your whole life. So the earlier we can catch that, the better. So if you have a family history of glaucoma in particular, it's very important to go early. So I guess a general rule of thumb is that when you're starting to need reading glasses to read up close, that's a good time to go to your optometrist and have a proper eye check. So sometime between the ages of 40 and 50. Often we just say 45 is a good place to start, to go along then, get your eye checked, and your optometrist will be able to pick up if you have any risks or signs of glaucoma and advise you when you should come back for a visit.
Got some lifestyle questions for you. So is lying in a prime position to be avoided, and likewise head below heart yoga positions?
Yes, well, we'll tackle the yoga one first, because yoga is very good for your overall health. There is no doubt about that. It creates a lot of calm, a lot of muscle strength. There are a lot of benefits. But some of the positions are not good for people with glaucoma. Now, there's no evidence that they do damage to people who don't have glaucoma. But if you have glaucoma, again, standing on your head can, like the doggy down position. I don't do yoga, so I'm not unsure of the whole name, but there's a list of them, can cause the pressure in the eye to increase. And again, that can cause a spike. Now, people will say, oh, I'm only in that position for a short period of time, and that's fine. But I tell you about one patient I had. She was a yoga instructor, and every time I saw her, her pressure was 10. But she had glaucoma, and she was getting these little, what we call nerve fiber layer hemorrhages, which are getting worse and worse. And I said to her, look, your glaucoma is really, your pressure is really low. I think we need to try to dig deeper about why you're getting such a rapid progression in your glaucoma. So I said, go into the waiting room and do your positions. And then after that, I will call you back in. And her pressure went from 10 to 24. Now, for her, it was relevant because she was doing it multiple classes several times a day. So it was all these spikes. So in general, we say that if you have, and you can do this, you can ask your doctor, say, can I go into your waiting room and do my down dog position. And then if you measure my pressure afterwards, because you may not be one of those people who has a spike with yoga, and we don't want to deprive you of that if you're not one of those people. Or you can do it in the waiting room, the doctor in their clinic room, and they can see another patient. So I always like to try it out. Say, let's just try it out, because while we have general rules, it doesn't necessarily apply to everyone. And we don't want you to change your lifestyle on something that may not be relevant for you. Mm-hmm. So the next question is about head position and sleeping. We do know that when your head is flat, your pressure in the eye is higher. So often we suggest, or some studies have suggested, sleeping with 1 or 2 pillows underneath your head. That lifts your head a little bit and doesn't cause the pressure to be as high when you sleep. Now, the risk with that is that when your head is up, your blood pressure is lower. So if you have low blood pressure, then it probably balances itself out, because when the pressure that's important is what we call the perfusion pressure. So you have blood pushing blood, your blood pressure is pushing the blood into the eye, and then you have the eye pressure resisting that blood coming into the eye. And the difference between those two in general principles is called the perfusion pressure. So what we do know is that when the perfusion pressure is very low, then you have a higher risk of getting glaucoma. So that if you have high blood pressure and you sleep with a few pillows, then that's actually good, because you're lowering the pressure in your eye, and your blood pressure is not low anyway, so it doesn't matter. But if your blood pressure is very low, then you need to discuss it with your doctor, your GP, and say, look, what are the issues? You know, how low does my blood pressure go if I sleep compared to lying down? And it may be better that in you that it makes no difference.
Brent is a swimmer, and he's asked if I have to swim using goggles and read that they increase eye pressure. I've had a trabeculectomy. Should I swim with goggles?
Well, look, if you've had a trabeculectomy, you're probably okay. It's the goggles can increase the pressure in the eye, but there's no study that shows that they do that once you've had a trabeculectomy. The studies have been in people who haven't had a trabeculectomy, and that causes increased orbital pressure. But if you've had a trabeculectomy, your trabeculectomy should be draining any buildup of fluid caused by the change in the optics or the physics of what the goggles cause. But there's so I would say if you've had a trabeculectomy, swim away.
Love it. Jules asked, my eyes water a lot. Is this caused by the drops I use?
It certainly may be caused by the drops you use. And again, when patients say to me, I think I have this side effect and it's from the drops, there's only one way to be certain, and that is to say, right, we're going to stop that drop and see if it goes away. Mm-hmm. And with most of the time with glaucoma, stopping a drop for 4 to 6 weeks is not going to cause enough damage or any damage to resolve the question being asked. If it's something like watery eyes, which is multifactorial, there's many causes of watery eyes. There's dry eye, there's blocked nasolacrimal ducts that can cause that. There's poor blinkage. There's where the lid positioning doesn't sit on the eye properly. So there's a whole range of causes for watery eye. And so you could just say, look, what I'm going to do is stop the drop. My eyes water every day. I'm going to stop the drops for 1 week after you've talked about it with your doctor, and see if the watery eye goes away. Sometimes we have some tablets that we can give you, which we don't use for long-term usage for glaucoma, but we can give you that in a short-term basis just to do the trial and see if that side effect actually is relevant to you or not from that drop.
Another question from Jenny. There are conflicting views on whether or not one should apply eye drops on the day of the appointment. Before the appointment?
No, there's no conflicting views at all. There's only one answer to that, and that is definitely, one more definitely. And the reason for that is this. So when you come to see your eye doctor, we want to know if the drops are lowering your pressure. And when you don't use a drop for 1 day, at least 20 to 30% of that effect, depending on the drop, sometimes 50% of that drop effect wears off. So you may come and your pressure, we're measuring your pressure is higher. And then we're thinking, gosh, we need to intensify treatment. So then I'm putting you on a second drop, or saying we need to do laser, or we need to talk about surgery, and actually you just haven't put your drop in that day. So I don't know what your pressure is with that drop if you don't put the drop in with that day. So it's very important to put that drop in. And I know that in my team, my nurses always ask, have you put your drops in today? So that if someone says, oh my goodness, I forgot, I'm not going to hold it against you, but it just means that the pressure measurement, I interpret with a grain of salt. I don't actually think, oh my gosh, the drop's not working, I need to put you on a stronger one, which may have more side effects, or a double action drop. I can say, look, just come back another day, pop in, and we'll measure your pressure. So absolutely, unless your doctor tells you not to, always use the drops exactly the same way as you do in the 6 months prior to your appointment. So we get an idea, a little snapshot of what your pressures are doing during that time.
And Chris has asked, are there any vitamins or health foods beneficial for glaucoma?
And that's a great question, Chris, and an area that, again, there's a lot of research on. So the most newest vitamin that's been thought to be helpful is vitamin B2, or niacin. And that was a study that was done in Melbourne. And now there's a big group in London also expanding that to see if it works in the long term. The doses are high, and therefore they can give you some side effects. It can give you flushing in your cheeks and a bit of vasodilation. So you need to talk about it with your GP to see if that works. But in the study that they did in Melbourne, they actually showed that patients who were on it for 6 weeks had difference in the electrical readings of their optic nerve. And they didn't use visual fields or vision as their outcome measure, because it was only a short study. They just used the electrical changes of your optic nerve. So the questions really from that study is that, do the electrical changes in the optic nerve mean that my vision is going to be better protected in the long term or not? So we will know the answer from that when the UK group completes their study, but certainly it's promising. And if patients ask me, that's one that I always suggest. I say, we can try it, we can see how you go with the dose. The second one is ginkgo, and ginkgo biloba has quite a large body of research, but mainly done in animals or rats. And certainly there's, in the lab and even in the test tube, there's a lot of potential theoretical reasons why ginkgo would be helpful. So it improves blood flow. And again, we were talking about perfusion pressure. It may also be an antioxidant. So it may also prevent the damage from inflammation that we talked about and serve as a neuroprotection. So ginkgo is another one that has some potential. And if people are interested in taking other medication, that's another one that I think has some merit. And certainly in normal pressure glaucoma, that's another one to consider. In terms of lifestyle, that's more tricky. Smoking isn't good for your eyes. So I think that we can take that one, take that as a given. There's no reason you should smoke anyway. So for the rest of you. So I think that we can definitely take that. But other than that, there haven't been a huge amount of evidence about dietary factors that can change the outcome of glaucoma. There's some preliminary evidence, and people have followed on from that to see if there's helpful. So carrots are one that there's some studies that say is associated with better outcome. If you have more carrots per week, your grandmother was correct. And in saying that, and also vegetables, kale and silver beet and things, they're certainly good for your macula. So there's no harm kind of introducing those. I guess the tough thing is to have macula degeneration and glaucoma, because that affects both your peripheral vision and your central vision. So I think it's always good to take an extra precaution and tend to do that. There's some evidence that salmon and fish oils help lubricate the drainage pathway, so that may help fluid flow out of the eye and may lower the pressure, but they're not very strong definitive studies that I can say, put my hand on my heart and say, this is going to make a difference. The only things that we have strong definitive studies are to lower the pressure. So that's
coffee.
Sorry?
What about coffee?
Very good question. So again, some people are caffeine responders. And some people who have coffee, their pressures can go high, 3 to 5 points higher. And again, I do the same thing. I say to them, buy your favorite cup of coffee from wherever you normally go. Don't drink it. Come to my office. Let me check the pressure first. Then I'll put you out into the waiting room. Drink your favorite cup of coffee, and then we'll measure the pressure 45 minutes, an hour again. Now, you could always drink my coffee in the coffee room, but mine may not be as strong as yours. So if you like very strong coffee, I always say bring your own, and then we can do that. But I have found some patients who are caffeine responders, and we tell them to cut back on the coffee. But to be honest, most of the time, most patients aren't caffeine responders. So, if you're like me and really need a good cup of coffee once a day, then I would hate to be deprived of that or deprive you of that if it wasn't necessary.
Yeah. Jenny's asked a question, is there cause for concern when the cup disc ratio is at 9 in both eyes?
That would be classified as advanced glaucoma. So if we think of the donut, if we think of a mouse eating a cheese donut, for example, with a hole in the middle, and the mouse starts from the inside of the hole and kind of eats its way out. A cup to disc ratio of 0.9 is when you just have a very thin rim of tissue and a big cup in the center, a big hole in the middle. So that's cup disc ratio. So cup disc ratio means that the cup or the hole in the inside is almost taken up the whole size of the optic nerve. So it's almost all hole and very little nerve tissue left. So that is what we would call advanced glaucoma.
Can high impact exercise impact your glaucoma?
Well, we did a study actually that was recently published in a British journal in weightlifting. So what we showed is that weightlifters, when they are lifting their weights, they actually have, during the time that they're having the increased resistance and it's above their head and they're pushing really, really high, their pressures went up to like 50 or 60. Huge spikes. So we don't know the long-term consequences. So these were normal gym bunnies. So these are people who went to the gym, but they actually did a lot of weightlifting and resistance weightlifting. I don't understand all the different types of machines they use because I don't weightlift myself, but we had Ehsan, who is one of the optometrists in the Department of Optometry. He spearheaded the study, and he's a professional quite a serious weightlifter himself. And so he designed a very elegant study, which showed that weightlifting can increase the pressure in the eye. But general aerobic exercise is actually good.
Good.
So, and some small weightlifting, I mean, we all need to keep our muscles strong. I mean, this is like serious weightlifting, over your head. But, some normal weightlifting is fine.
Prasad has asked, my father was using drops for glaucoma for many years. Recently, his doctor asked him to stop eye drops as his pressure is normal for a few months. Is it possible that his eye pressure, I've lost the message.
I've got the gist of it, though.
Got the gist of it? Yeah.
I've got the gist of it. So I think that's a very good question. So sometimes patients will be started on eye drops because they have what we call ocular hypertension. So that means they have high pressure, but no real damage to the optic nerve. So they have a normal optic nerve, they have a normal visual field, but they have high pressure. And because pressure is the only treatable risk factor, sometimes we treat ocular hypertension to prevent people from getting glaucoma. And after a while, so we don't know the natural natural history of ocular hypertension. So do people with ocular hypertension always have it, or do they bounce up and down, or can they come back down if their life circumstances changes? We don't know. So if someone's been on treatment a long time, like Prasad's father, it's very reasonable for the ophthalmologist to say, look, let's give you what we call a drug holiday. Now, that's not a drug holiday in the normal sense of the term, where we're putting you on kind of psychotropic drugs, but we're giving you a drug holiday, a break from your drops. And then that's a good time for the eye to have a bit of a rest, especially if you don't have glaucoma and you only have ocular hypertension, and then to remeasure your baseline and see where you're at, and to see if actually you still need it or whether it's still as high as it was when you first started on treatment. And I think that's a very safe and sound approach to take. And it may mean I've done that with patients, and sometimes we just haven't gone back on drops for some reason. Their pressures have normalized. We continue to follow them because you don't know when they can spike again, or you don't know what pressure may be causing damage to their optic nerve. So you need to continue to have those assessments done to make sure you don't have damage at a lower pressure, but it's a very reasonable thing to do.
Very good. And Colin has just asked, I have low pressure glaucoma in one eye. Should I put eye drops in the eye that's not showing signs of damage?
That's a very good question. And that is quite controversial. There are different opinions about that. And I will give you the reasons behind that. So the purist will say, only treat the eye with damage. So if you've got glaucoma in one eye, just treat that eye, because you don't know if the other eye is going to get damage. It may never need treatment. Some patients have unilateral glaucoma. And if you're coming back for your visits anyway, your doctor will be checking the other eye every time you come back. They'll be doing the visual field, they'll be doing the OCT scans, and they'll be looking at both optic nerves and doing the pressure. So I always say, if you bring both eyes, I'm going to examine both eyes. So it's very important to have a look at both eyes every time a patient comes to you. And so therefore, I'm sure all doctors are like that. So they would pick up problems in your non-normal eye if it started to happen. And then you could start to have treatment at that time. So if you, by not having the drops, you're saved the disadvantage of the potential side effects of the drops, the uncomfortable eyes, itchy eyes, red eyes, which sometimes can occur. But some drops give you side effects, like they make your eyelashes grow, the prostaglandin family. So that's latanoprost, latine, Travatan, Travoprost, and Bimatoprost are the ones we have in New Zealand, and they make your eyelashes grow. So sometimes putting a drop once a week in the other eye, or even every other day in the other eye, if you're at risk for glaucoma, will give you equally luscious long eyelashes on both sides, rather than one side only. And people say, why did you forget to put the mascara on the other eye? So sometimes it's done for convenience. But if one eye is completely normal and you're not noticing the side effect differences between the two eyes, and your doctor's following you anyway, it's reasonable just to treat one eye.
Great. I think we've answered the questions, Helen.
Wonderful. Well, I think we've actually come to the end of that hour has just flown by.
It has. Thank you so much. It's been very interesting, and I'm sure you've answered a lot of the questions that our patients did have. And more.
Thank you. Well, it's thank you everyone for turning up. It's wonderful to see patients engaged with their glaucoma, and that's what Glaucoma New Zealand is here for, is to kind of bring you as much evidence and information and support, so that you can to support you through your glaucoma journey, but so you can also share the message with other people and your family, so they can go along and get their eyes checked. Because our goal ultimately is to make sure every person with glaucoma in New Zealand is diagnosed and every person is on treatment. So thank you all very much for your interest and support for Glaucoma New Zealand. I would like to thank Pippa. She is an amazing general manager for Glaucoma New Zealand. Since she started at a very different difficult time through COVID, and she's really made some innovative measures such as this symposium series, and she's always there at the end of a phone, her and her team, to answer a question or to give you some guidance. So we're lucky to have her, but please use her as to help you through your journey.
Thank you, Helen. And yes, please do reach out if you have questions. We're very lucky to have Helen and many of those New Zealand ophthalmologists at our beck and call to ask the questions if we're not sure. But thank you very much for your time, Helen, and thank you everybody for joining us. The next session is with Jessie Gale on the, better check that one, on the 28th of April.
And you'll enjoy Dr. Jesse Gale. He's fantastic. And is he going to talk about research?
He's going to talk about future technologies.
Yeah, he's fantastic. So that's certainly one to come and listen to.
We'll have that up on our website tomorrow if anyone would like to register. So thank you, everybody. Thank you very much for your time and your questions. We'll bid you good night.
Good night, everyone. Good night.